Hey everybody, thanks for joining today. For office hours, we'll be talking about patient access with David Byrd, our Vice President of Growth and Strategy. Nice to have you, David.
Nice to be here. Thanks.
So yeah, we just kind of wanted to run through a few questions regarding patient access, the different problems that we see with our clients, how we help the most for these practices. So just to jump right into it. So David, what common patient access problems do you see right now in the market?
So let me first define what we're referring to as patient access before I answer that question, because I think it's important. Some people have different ideas around patient access than others. So from my standpoint and the way that Infinix looks at it is patient access professionals handle the registration and support for the patient. But they're also doing it for the provider and the payers throughout the whole patient experience. So the way I like to look at it is patient access is different from RCM, but it has a significant impact on RCM. I would suggest that patient access is when the patient first interacts with a healthcare professional to schedule a procedure or a test, and it stops once the coding of the encounter starts to take place on the RCM side. So that's how we think of patient access. So the breakdowns run the gamut. I mean, there's all kinds of breakdowns in patient access, from does the patient have insurance? Are they eligible? What are the benefits around that eligibility of the coverage for the patient? What's their deductible? What's their copay? Does the test or procedure need a prior authorization? All of these activities, and there's much more, but from a high level, that's basically it. Can create breakdowns if the facility does not have the proper processes addressing workflow, technologies, people, and shared knowledge versus tribal knowledge. Meaning, does the patient access staff understand the components of the workflow and how those tie together across the board? Or do you have a patient access department where one individual has a lot of knowledge, but that knowledge hasn't been shared? So the challenges and the breakdowns are extremely vast if there's no process there.
Yeah, that makes total sense. And it's not always cut and dry with patient access. Each specialty has their own requirements. Each facility will do it different ways. So sometimes it's nice to have it standardized if possible. Kind of looking at providers here, David, do you think they're aware of their patient access challenges?
It's a good question. It's a funny question because I think they definitely become aware when denials start happening on the back end of the RCM process caused by, the upstream data or the lack thereof, or just simply bad data. But more times than not, they try to fix the RCM of on that side of the fence versus looking for the root cause, which can be from the patient access side. So I think providers become aware based upon certain issues that are happening, but once they become aware, it's too late. And they typically start on the RCM side versus saying, what's happened upstream, because all of that data flows downstream into the billing system and finally to the claim. And that's where you'll start to see denials and write-offs.
Yeah, totally agree. And when providers do look at it from the RCM perspective, that's almost like a reactionary measure because something went wrong. Whereas if you look at the patient access side, of kind of be more proactive and getting those claims, coded right and eligibility and benefits right, from the time when the patient first comes in. Do you think that providers are able to pinpoint, where their challenges really fall?
I think they can if they have good proper management and protocols in place. When you look at how process impacts reimbursement, I'm a true believer that people for the most part, aren't the problem. For the most part, when it comes to like collecting reimbursement, I always say 80% of the problem is process and 20%, if that, is people. Poor process has a tremendous impact on net patient revenue. From a point of service collection to patient pay estimation to denials, to appeals, to write-offs. When you look at the data, you always see eligibility or prior authorizations required and medical necessity in the top denial buckets. And what that means is the upfront process more than likely needs to be looked at, because those denials cost hospitals and providers a ton of work and rework for that matter, and thus revenue. But beyond that, it also plays into patient satisfaction as well. And I always like to bring this up, because when people look at patient access or RCM, they're always looking at the data elements, what they have to do, what they have to collect, and they forget about the patient's interaction from a clinical standpoint. That patient can have the best clinical experience of their life, but once you start screwing up their invoices, they forget about that experience. And that patient satisfaction, which is becoming greater and greater in healthcare today, plays a direct impact from a billing or invoicing part. I think our audience probably has a lot of experience dealing with irate patients, or for that matter, the denials and the rejections and the write-offs also impact the physician's pocketbook. So don't want to go into that detail, but I'm sure our audience can understand that.
Definitely. And maybe if we're talking about a provider who's not as well versed within the challenges within RCM, but they have a gut feeling like, hey, maybe something's not right. I don't think our patient access process in general is that strong. Where's a good place to start with that?
So I think I mentioned this before, but right, patient access is different from RCM, but yet they both tie to make ends meet. You have to start at the root cause, and the root cause is more than likely going to go back to the lack of process. Why is the person at the front desk not checking eligibility? Is there too many things on their plate? Is there a lack of technology to assist? Has that person not been trained appropriately? Back engineering into the problem is a great way to assess process. And what I mean by that is we know we have a problem with, let's say, prior authorization denials. What is the workflow process to the auth number getting to the claim, right? Breaking down that process at the claim level and then working all the way back into intake, for example, takes work, but it's definitely going to identify the problem in the process. And the process may be sound, and that's what you identify, but perhaps it becomes a staffing issue where you're realizing that, hey, our process is pretty good, but the amount of auth that we have flowing through the system and then downstream to the claim, because if you're short-staffed and steps are simply being missed due to that volume, things that the staff don't have in their control, then it becomes a staffing issue. It's not so much a process issue, but you've identified within the process breakdown, hey, we're understaffed here, and that's where you have to start to look at solutions for understaffing, which the healthcare market is experiencing right now.
Yeah, and you're not lying about that. Staffing issues across the country, and I heard you list a lot of different challenges there. But the one that caught my mind the most was technology. I know there's a lot of different technologies out there, analytics, automating certain processes. Can you go into how technology can really help streamline your patient access, process?
Yeah, so again, I'm a true believer that 80% of challenges or problems are due to a lack of process. And what technology does is it institutes process and workflows that can be measured through analytics and can be really configured to different operating functions, whether that's for eligibility and benefits, whether that's for patient pay estimation, patient outreach, which is becoming bigger and bigger and bigger, and the point of service collections. I think sometimes people, fear that technology will eventually put them out of a job, but technology is there to support the user, make them more productive, and allow them to focus on truly what their objectives are and eliminate some of the stress of their day-to-day task. I mean, Randy, you may not remember this because of your age, but when voice recognition came out, everyone thought transcriptionists were going away. When natural language processing hit the healthcare market via computer-assisted coding, people thought coders were going to be eliminated. None of that has happened. Matter of fact, it's just made coders more productive. It's made them more astute. We still have transcription to this day. It's made them more productive because essentially what they're doing now is auditing what the voice rec has produced. They're still interacting with physicians. So it's only made those functions more productive and less stressful. And I think, when you have an opportunity to institute technologies across some of the areas that I just mentioned in patient access, it's going to force the issue of process, but more than that, it's going to allow those facilities and those managers and those CFOs to really analyze what's going on at the patient access level through concrete evidence through those technologies.
100%. And, kind of like you said earlier, it all comes back down to the patient and their experience. And, if you're looking at technology and the way it can help your patient access product or process, turnaround times, getting that patient in the door quicker, when they come to the clinic, are they verified? Are they eligible? Do they have benefits? Stuff like that can really help the patient get seen, which would, overall increase your care. So it's really important to have the right technology with the patient access solution.
Absolutely correct.
Well, that's all the questions I had. If there's any questions from the audience, you can go ahead and put them in our chat. And if not, we can hop off, David. I don't see any questions currently.
Okay. Appreciate the time. Thank you.
Yeah. Thank you for everyone who joined. Thank you, David. Have a good rest of y'all's day.
Thanks.